Yes, friends, am I visible? So just confirm if my audio and video are working fine. Hello, Nischay. Hi, hello, Dr. Ria. Haru. Can you please confirm if my audio and video are working fine? AV are fine. Hello, Dr. Devi Kulkarni. Thank you so much for the confirmation. So, my brief introduction about myself. I am Dr. Maddineni Srinivas, your dermatology faculty in Cerebellum Academy. So, I have done my MBBS from Government Siddharth Medical College, Vijayawada, and I have done my diploma from GSS Hospital, Mysore. After which I have secured 5th rank in secondary DNB, and I have done my DNB from Hindu Hospital, New Delhi. So these are the vision and mission of Cerebellum. So basically we would like to help you out, students. So in this particular Dharma lecture, we are going to cover previous year questions, image based questions, and a very quick review, basically you can say, of entire dermatology. So after attending this lecture, what is next? Next end is what is next. So after this, you are going to get an annotated PDF, which I will share shortly in my Telegram group, and also it will be shared in Cerebellum Telegram group as well. And what I have done is I have included so many images and so many points which are very important previous year questions. So you have to focus on the underlined points in this presentation, okay? And not only just the presentation and the matter, and also this session is going to have even more antaku minchi atikku mele, so super se bhi upar. Okay, so what will be there? Some motivation will be there. So basically all of us have joined MBBS, and we have been confused state when we joined MBBS, some of us. Okay, even I was confused state initially. So we thought, this is from a movie. So can anyone tell what is the name of the movie? Yes, anybody? Yes, SMC Vijayawada. Yes, friends. So please, can anyone tell what is the name of this movie? Oh, thank you so much, Mohit. I am very much happy by knowing that. So this is from Lakshya movie. I hope everyone might be knowing. Yes, thank you so much, Nischay. So I am not a singer like Shankar Mahadevan or anyone, but just try to sing some lines. So we all were confused, and we like the lyrics are very much apt. मैं ऐसा क्यों हूँ, मैं ऐसा क्यों हूँ, मैं जैसा हूँ, मैं वैसा क्यों हूँ, करना है क्या मुझको ये मैंने कब है जाना, लगता है गाऊंगा जिंदगी भर बस ये गाना, होगा जाने मेरा अब क्या ओ. So what does this mean is I am so much confused. I don't know what to do. In this movie actually hero was very much confused. He was just roaming around with his friends, passing the time, but suddenly some incident happens and he thinks to join army. Okay, from that onward there are drastic changes. We will see the rest of the song at the end if there is time, but what I want to tell for all of you is, see, failing to plan is equal to planning to fail. So even if you are attempting this 5th March exam, what I want to tell you is, write down in a piece of paper. Okay, it can be hard copy of a paper, it can be virtual, in the notes, in the tab. Everyone is having tab right nowadays. So with a pen, write down what are your strengths, weaknesses, what are the opportunities you have, and what are the threats. So SWOT analysis basically. So from your grand test, you might be knowing which subject you are weak in. So these weak subjects, try to focus mainly on those subjects and try to revise them. They are the and also try to read the volatile topics, which are very very likely that you might make a mistake in the exam. Okay, in between option A, B, C, D, most likely you will eliminate 2 of the options, and in the 2 more options you will be having this difficulty. Okay, so with this analysis, with this planning in this last 1 week, which is very very crucial, try to identify the volatile topics for you. Try to identify what are the topics which you need to revise again. Okay, our brain is very great, no doubt, but if planning is not done, then this great brain also fails. Okay, so let us start with vesiculobullous disorders. Okay, so I hope everyone is with me. Singing, yeah, thank you so much. Yes, let us start with some of the primary lesions. Okay, everything is a question in this presentation, so try to be with me till the end, and I will try to cover in 1 hour or 1.5 hours at the most. Okay, so let us see vesicle and bulla. These are the primary lesions which we see in vesiculobullous lesions. So fluid filled lesions less than 1 centimeter are vesicles. Fluid filled lesions which are more than 1 centimeter are called as bulla. So as you can see, this is vesicle and this is bulla. And if the vesicles are bulla, they are going to rupture. They are going to leave behind erosion, which is basically focal or total loss of epidermis. Focal or total loss of epidermis. So this is an erosion, and also if the erosion becomes more deeper with the involvement of the dermis involvement, then we call it as an ulcer. And we can see some secondary lesions, which is crust. In the case of vesiculobullous disorders, crust is basically serum, pus or blood when it gets dried up on the skin surface and it forms a hard exudate. So please remember this very important MCQ, non-bullous impetigo, which is also called as impetigo contagiosa, is going to have a honey colored crust, So don't think that only vesiculobullous disorders topic is going to be covered. In between, I will try to include some of the questions from other topics as well. So very important sign, Nikolsky's sign. So in this, basically what we are going to do is we are going to apply a tangential pressure over the skin. Tangential pressure will be applied where there will be what will happen, upper layers of the epidermis, they are going to peel off from the underlying dermis. Okay, so this is referred to as Nikolsky's sign. So can anyone tell me Nikolsky's sign is positive in which all conditions? Yes, small question for all of you. Please try to be interactive. It should not be that I am only the one who is speaking, so you should also be interacting with me. So dermat images are very confusing, sir. Yes, Devi Kulkarni, I can understand. Yes, please try to answer this question. Nikolsky's sign can be positive in which conditions? Very good, Kirti. It is pemphigus, no doubt. Yes, very good. Staphylococcal scarlet skin syndrome, it can also be positive in this. Yeah, no, psoriasis, no, it cannot be. So SJS, Dr. Divya has told SJS, please remember there is one more entity called as pseudo-Nikolsky sign. So just remember Nikolsky sign, the underlying pathogenesis which is going to happen is there is going to be acantholysis. Whereas in pseudo-Nikolsky sign, which is seen in Stevens-Johnson syndrome and toxic epidermal necrolysis, the underlying mechanism is necrosis. So there in pseudo-Nikolsky sign also there is going to be peeling off of the superficial layers of epidermis from the underlying dermis, but here the underlying mechanism is necrosis instead of acantholysis. Please remember, okay. So please remember in pemphigus vulgaris, patients are going to have mucosal erosions. Almost 90 to 95% of the patients are going to have mucosal erosions. So you can see buccal mucosal erosions, and also gingiva is also involved, forming erosions and ulcerations. So a very important differentiation between intraepidermal split and subepidermal split. So please remember the intraepidermal split, the disease which is the the brand ambassador for intraepidermal split is pemphigus group of disorders, and subepidermal split is, we can say, bullous pemphigoid and dermatitis herpetiformis. Okay. So please remember in intraepidermal split there is going to be a thin roof, whereas in subepidermal split there is going to be a very thick roof which is formed, and because of this the bulla which we can see in intraepidermal split is flaccid bulla, whereas a subepidermal split condition, bullous pemphigoid, we are going to see tense bulla. This is very, very important point which was asked in various exams previously. And the flaccid bulla is going to present with wrinkling on the surface. Wrinkling will be present, whereas in the tense bulla, the bulla is not going to have any wrinkling on its surface, and it is going to be just like a balloon. Okay, so I just want to show you one yes, analogy. With one analogy you can remember this tense bulla. So when I was in Delhi doing my DNB, so there was Holi which was celebrated, during which time the balloons which consisted of color water were thrown over me from top of the buildings. So this was very routine in Delhi, and they call it as Burana Mano Holi Hai. This was from the film Sholay. So these are the water balloons. So from this, what I want you all to remember is Bura na mano holi hai. Bura na mano holi hai. So bullous pemphigoid, B-U-L, bullous pemphigoid. So in this condition, bullous pemphigoid, we are going to see the tense bullae just like this water balloons. Okay, tense bullae will be seen in the clinical features. Very, very important. Okay, flaccid bullae are seen in pemphigus, whereas tense bullae are seen in bullous pemphigoid. Very, very important for you to remember. And so I just want to tell you one more thing. This is a very famous dialogue by Gabbar Singh. Jo dar gaya samjho mar gaya. Okay, jo dar gaya samjho mar gaya. So fear, you can have two meanings from fear: forget everything and run, or face everything and rise. So the choice is ours. So ultimately, for everything we have to choose between the good and bad. Okay, so I hope all my students are going to choose this: face everything and rise. And also remember, if you are having little bit of stress, that is very bad. Why? Because only having little stress is going to give you boredom. So if you are having good amount of stress, then it is going to improve your performance and up to a certain level. But if the stress increases a lot, then what will happen is you are going to become tired and you are going to get exhausted. So optimal level of stress or optimal level of fear are very good. Fear is also two types. Okay, physiological fear and pathological fear. In pathological fear, because of the amount of work which is there in front of you, you might get paralyzed. But physiological fear is very important. That is going to drive you to do the revisions, to do the study daily, on a daily basis, for 12 to 13 hours also. Okay, so coming back to our lecture, this is the patient of pemphigus vulgaris. So as rightly told by the desmoglein 3 by the students Jitu and Akhilesh, very good. So in this condition, desmoglein 3 is involved more than desmoglein 1. Because of the desmoglein 3 having antibodies, there will be mucosal lesions. And because of the desmoglein 1, there is going to be skin involvement. Skin involvement, as you can see, there will be extensive skin involvement. And this is Zhang smear. This is Zhang smear. So can anyone tell me what are these cells? This is the cell which I am marking here, which are round cells which are having perinuclear halo and a hyperchromatic nucleus. So can anyone tell what are these cells? So please try to. Yes, Dr. Vaishnavi, leprosy करेंगे हम. Akhilesh, leprosy is hard. Yes, I can understand. Will appear for sure. Yeah, leprosy is very important. So can you tell me what are these cells called as? Please, anyone? Yes, very good. They are called as acantholytic cells, and please remember, acantholytic cells. Acantholytic cells are nothing but they are the keratinocytes which have lost their connections, intercellular connections with each other, and they have become rounded. Okay, so they are basically keratinocytes. And these are also called as Zhang cells. These are also called as Zhang cells. These are also called as Zhang cells. So just contrast multinucleated giant cells. Multinucleated giant cells are also seen on Zhang smear. And these can be seen in which infections? Can anyone tell me what are the infections in which we can see the multinucleated giant cells? This was the MCQ which was asked in the recent INSCT exam. Yes, anybody? Yes, very good. K gamer. Herpes simplex viral infections. Okay, herpes simplex virus 1, 2, and also in 3, we can see these multinucleated germ cells. And one more point, even the acantholytic cells are also seen in herpes simplex viral infections. And these acantholytic cells are also seen in pemphigus vulgaris, pemphigus foliaceus, staphylococcal scarlet skin syndrome. Okay. So very important for you to remember what are the conditions in which we can see these two types of cells. And please remember, in the histopathology of pemphigus vulgaris, we are going to have this characteristic row of tombstone appearance, and the basic reason for the appearance is because of the hemidesmosomes. Hemidesmosomes. See, basically if you consider these are the stratum basal cells, so the stratum basal cells are connected to each other with the help of desmosomes, whereas the stratum basal cells are connected to the underlying dermis. So if you consider this is the dermis and this is the epidermis, the hemidesmosomes are going to help in connecting. These are the hemidesmosomes which will help in connecting the stratum basal cells to the underlying dermis. And because hemidesmosomes do not have any antibodies in pemphigus vulgaris, so the stratum basal cells are connected, they are just connected to the underlying dermis, giving a row of tombstone appearance on histopathological examination. Very important point. And what is the diagnostic investigation? What is the investigation of choice in the case of vesiculobullous disorders? Can anyone put your answer in the comment section? Yes, very good, Goodwill. Supra-basal split is seen. Very good. Supra-basal split is seen. Supra-basal split. Yes, this is the investigation of choice in the vesiculobullous disorders. Can anyone tell what is the name of this investigation? Yes, fishnet pattern, or we can say chicken wire pattern. Yes, it is direct immunofluorescence, DIF, where we are going to see fishnet pattern or chicken wire pattern, due to the IgG and C3 antibodies. Okay, IgG and C3 autoantibodies. And these are, just to summarize some of the points related to pemphigus vulgaris and pemphigus foliaceus. Pemphigus vulgaris and pemphigus foliaceus. So I will just try to highlight. So here in foliaceus, you can see desmoglein 1 is the target antigen, and please remember because of which oral lesions are absent. Whereas in the case of pemphigus vulgaris, desmoglein 3 is more commonly involved, having antibodies. That is the reason why oral lesions are seen in more than 95% of the patients. Okay, and what is the reason in pemphigus foliaceus there are no oral lesions? Because desmoglein 3 is present mainly in the mucosa. Desmoglein 3. Whereas in foliaceus, desmoglein 1 is having antibodies, so oral mucosa and also other mucosa is spare. So coming to the bullous pemphigoid, please remember, as you can remember, we have seen tense bulla are seen in bullous pemphigoid, and you can get these points given in the MCQ that these tense bullae are present over erythematous base. Tense bullae on erythematous base. Because the underlying skin is going to have urticarial wheals. Okay, very important point. And settled bulla, the bulla, when they rupture, the fluid will be let out and the bulla are going to settle down. This is a characteristic feature of bullous pemphigoid. Okay, please remember this point. And in the case of bullous pemphigoid, the direct immunofluorescence is going to show a linear pattern of IgG and C3, where the deposition of the antibodies is along the basement membrane zone. Why? Because the antibodies in bullous pemphigoid are going to target hemidesmosomes. Basically, it is BPAG2 more than BPAG1. So here are the points. So you can see pemphigus vulgaris is an intraepidermal disorder, bullous pemphigoid is a subepidermal disorder. Desmoglein 3 is having the target antibodies, whereas here it is BPG 2 more than 1. And please remember, most important point, acantholysis is present in the case of pemphigus vulgaris, whereas in bullous pemphigoid acantholysis is absent. And because acantholysis is present in pemphigus vulgaris, Nikolsky sign is positive in pemphigus vulgaris, whereas in bullous pemphigoid Nikolsky sign is negative. Okay, very important points. All of these are very important points. And this is a condition which is dermatitis herpetiformis, where we are going to see, instead of intact vesicles or burra, we are going to see mainly excoriations which are present over extensors. So excoriations on extensors will be seen, extensors will be seen, and this is also known as Duhring-Brock's disease. This was also one previous MCQ. And please remember, on direct immunofluorescence, IgA deposition is going to be seen along the basement membrane zone in a granular pattern. So each and every point is very important, previous year question. So you can see here, this is the IgA which is deposited in a granular pattern in the case of dermatitis herpetiformis. And please remember, the treatment of choice is gluten-free diet. Why? Because gluten is associated with etiopathogenesis of dermatitis herpetiformis, whereas the drug of choice is dapsone. Drug of choice is dapsone. And please remember, there are certain conditions which are genetic conditions. Please remember, these are genetic conditions which are mechanobullous disorders, which are having this term epidermolysis bullosa in their name. So basically we have three types of epidermolysis bullosa: simplex, junctional and dystrophica. So these three are the mechanobullous disorders, whereas there is one type of epidermolysis bullosa which is called as acquisita, which is not a genetic disorder. It is not a genetic disorder. Okay, so here blister or bulla are going to form due to mechanical injury, and in the MCQ the examiner is going to give you some of the clues, like there is a history of consanguineous marriage, or there is a history where mom is handling the baby while bathing or while breastfeeding. Then because of this mechanical trauma, there are blisters which are produced. Okay, this is going to be the history which will be given in the MCQ. Please remember, because this is a genetic disorder, there are no antibodies in this condition, so the DIF is going to be negative in this condition. Yes, papillary tip microabscesses are the histopathological finding in dermatitis herpetiformis. Very good, Goodwill, you are absolutely correct. So now let us move on to the sexually transmitted disorders. So first one, which is important, which is asked in the recent exams very frequently, is syphilis. So primary syphilis, it is also called as Hart-Shankar, in which we are going to see single clean based indurated painless ulcer which will not bleed on touch. So this is the classical description of a primary syphilitic ulcer. And there is a 1+1 offer if you remember the primary syphilitic ulcer characteristics. If you can remember this, then automatically you can remember the characteristic of ulcer of chancroid. Why? Because the features are exactly opposite in the case of chancroid, which we'll see in a moment. But in the primary syphilis, which is produced by Treponema pallidum, the treatment which we give is benzathine penicillin. But if the patient is not treated properly, or if treatment is not given, then Treponema pallidum, they are going to spread hematogenously, and they are going to produce what is called as secondary syphilis, in which polymorphic lesions can be seen. But the characteristic peculiar lesions which are seen are these hyperpigmented macules which are present, over the palms and soles. So there is one associated sign which is called as Buschke-Ollendorff sign. So in this, what happens is, on pressing these lesions with the help of an awl pin, if we press with the blunt end of this pin, what will happen is the patient is going to wince with a pain because of the deep dermal tenderness. So because of the deep dermal tenderness, the patient is going to have a lot of pain. This is called as Buschke-Ollendorff sign. Very important. This was asked previously. And in secondary syphilis, we are going to see mucosal lesions in the form of mucus patches, which are referred to as snail track ulcers, So here you are able to see the mucosa is having these ulcers which are just looking like the snail track, okay. And please remember one very important point, that these are painless. These are painless mucosal ulcers, okay. So make small steps every day. So ultimately you are going to reach whatever point you want to reach, the goal which you want to reach. And in the case of secondary syphilis, we can see mucosal lesions which are very important, which are called as condyloma lata. So just remember, lata means flat. Why? Because the lesions here are flat topped moist papules and plaques. So as you can see in the image, they are moist papules and plaques which are seen near the genitalia in the groin, okay. These are called as condyloma lata. And there is one very important disease which is condyloma acuminata, which are nothing but anogenital warts. And this condyloma acuminata is because of human papilloma virus. Very important, friends. Very important point which you must remember. Yes, very good, Devi Kulkarni. Shorty lymph nodes are seen in the case of syphilis. So I will try to give you an approach to a patient who comes with genital ulcer disease, okay, at the end. So these are the anogenital warts which you are able to see, which will present with cauliflower-like hypertrophic hyperkeratotic masses over female genitalia and also the male genitalia, okay. Very good. They are HPV 6 and 11. Very good. So these two are low risk. Type of human papilloma viral strains. Okay, please remember, number 16 and 18 are high risk HPV strains which are associated with malignancy. Okay, and most common is HPV 6 amongst the subtypes. And after this primary and secondary stages of the syphilis, ultimately the patient will land up into the next stage, which is latent syphilis, which is again divided into early latent syphilis and late latent syphilis. And in the early latent syphilis, patient is infectious, that is, the patient can spread the treponema pallidum to the sexual partner, whereas in the case of late latent syphilis, the patient cannot spread, that is, the patient is not infectious, but the patients are going to suffer all the the CVS is going to be involved, CNS is going to be involved in these patients, okay. And you can remember that in the latent syphilis, the patients are not going to have any kinds of symptoms or signs. And the investigation of choice here is enzyme immunoassay. So one more point which I want to add, in the secondary syphilis, can anyone tell what is the investigation of choice in the secondary syphilis? Yes, Apu, please put your answer in the comment section. What is the secondary syphilis? Investigation of choice for secondary syphilis? Yes, anybody? Dr. Goodwill, I have told in the initial slides of this video itself that PDF will be shared. The annotated PDF will be shared after the session is completed in Cerebellum Telegram group and also in my Telegram group. Okay. So yes, please, can anyone answer my question? So what is investigation of choice in secondary syphilis? Yes, please put your answer. Yes, very good, Haru. It is VDRL. Okay. Please remember this. And what is the investigation of choice in primary syphilis? Very important. It was asked previously. Okay. Yes. So from your microbiology knowledge, what is the investigation of choice in the primary syphilis? So I will give you a clue. Corkscrew motility of Treponema pallidum can be seen in that investigation. Corkscrew motility. Corkscrew motility can be seen in the primary syphilis stage. Yes, anybody? Dark ground illumination, very very important friends. Dark ground illumination, okay, you should definitely answer this right, okay. Dark ground illumination, very good. Dark ground, dark field, yes, yes, very good. So in the tertiary syphilis, just remember gamma can be found and CVS can be involved, and even nervous system can be involved, because of which patients are going to have, tape's dorsalis or general paresis of insane. And coming to the next type of syphilis, which is congenital syphilis, in which the infected mother is going to spread the treponema pallidum through the blood to the fetus in utero itself, in utero. And can anyone tell me, in congenital syphilis, will we see a primary syphilitic stage? Will we see a primary Shankar stage? Yes, yes or no? Yes, very good. All of you have answered it right. Dark field, very good. Yes, my question to all of you is, in congenital syphilis, can we see a primary syphilitic ulcer stage? Yes or no? So there will not be, no ulcer will be there. No Shankar. Yes, very good. No ulcer will be there. So there is one more condition called as syphilis d'emblée. Syphilis d'emblée, which is seen in individuals who got blood transfusion from a treponema pallidum infected person. So the donor is having syphilis and the treponema pallidum is present in the blood, and the recipient, unfortunately, even though he is not having any sexual intercourse, but because of the blood is having the treponema pallidum, patient directly develops secondary syphilitic stage, which is called as syphilis d'emblée. Okay, this was also previous MCQ. So in the congenital syphilis, no primary stage will be seen. So please remember, we have early congenital syphilis, which will have a triad, as rightly mentioned by many students. So which is going to consist of snuffles, which is persistent rhinitis. So as you can see, Niagara Falls coming through the nose, and the second part of the triad is hepatosplenomegaly, and the third component is vesiculobullous lesions. Vesiculobullous lesions over palms and soles. So this is the triad which is seen in early congenital syphilis. So these are the Niagara Falls which you are able to see. And coming to late congenital syphilis, as very good, so many students have told, it is Hutchinson triad, which is going to have Hutchinson's teeth, which is peg shaped or notched upper central incisors, and we can also see along with this two more features. So in the yesterday's ophthalmology class, you have seen interstitial keratitis and even the ENT involvement, that is sensory neural hearing loss. So these three are going to form the triad in late congenital syphilis. So in late congenital syphilis, we can also see anterior aspect of the tibia is going to be bend like this, just like a sword. So it is called saber tibia. And I hope all of you do remember this movie. What is this movie name? Can anyone tell which this hero is holding this sword? Yes, can anyone tell me what is the movie name? Yes. So Goodwill is giving mnemonic. You can remember with the HSC. Okay, very good. That is helpful, I guess. Yes, can anyone tell what is this movie? So this is Bahubali. I hope you know the director is Rajamouli, and please remember, even such a such a great director, we can say, is also telling that I wasn't confident, but I wanted to appear confident. So always, when you are preparing any exam, not only this. You should appear confident, you should feel confident, you should believe in yourself always. Though you might be knowing that you have some weaknesses, though you might know that you have not revised some topics at the end, but still you should have that contents inside your heart while going to the exam, in the exam hall also. Why? Because if you have that positive attitude, then even the questions which you don't know, sometimes you can mark them correct. But if you don't have this attitude, if you don't have this belief in yourself, I have myself experienced this, that we do make mistakes of the questions which we have learned already before the exam. Okay, So having this belief is the most important thing. Be confident, be confident, be confident in the exam, before the exam. So now let us move on to chancroid. Let us now move on to chancroid. Why did Kattap Angle Bahubali? Yes, so very good. Chancroid is caused by Haemophilus ducrei, and at my time there was Conrad Fisher who taught medicine. So he told this trick. Conrad Fisher, you can Google and see. He is a very famous lecturer, faculty for USML. So Haemophilus ducrei. Haemophilus ducrei is what is the crazy mnemonic or trick with the help of which you can remember that in chancroid both ulcer as well as lymphadenopathy are painful, okay, very very important. And as I've already told you, this is a 1+1 offer, so I will vanish myself, okay. So in the chancroid, which is caused by Haemophilus ducrei, it is also called as soft chancre. It is also called as soft chancre. We are going to see multiple ulcers in contrast to single ulcer. Here the base is necrosed and there is no induration here. There is no induration here. And the ulcer is extremely painful, extremely painful. That is the reason why the patient will do cry. And the name of the organism is Haemophilus ducrei, guys. Haemophilus. It will love blood, Haemophilus. So that is the reason why the ulcer is going to easily bleed on touch, I hope this helps. And this is the clinical picture of chancroid. This is a clinical picture of chancroid where you are able to see multiple ulcers. If you palpate, they will be very soft, and yes, as told by many students, very good. In chancroid, we are going to see on gram stain the cocobacilli which are present one after the other in the form of railroad track or school of fish appearance. Very very important terms which are given in the exam, okay, you must know them. And coming to the next genital ulcer disease, donovanosis, it is also known as granuloma inguinale, or it is also known as granuloma venereum. And please remember guys, that the name of the organism which produces donovanosis is not Leishmania donovani. Please remember, some students do make this. It is not Leishmania donovani, but it is Klebsiella granulomatis or Kellimatobacterium granulomatis. Okay, please remember this. And here also there is one more trick for you. Do no vanosis. Do no hai yahan par. So this is Hindi actually. Do no. So what are the two no's? So first one is ulcer is absolutely painless, so no pain in the ulcer. And one more no is no lymphadenopathy. So in donovanosis there is no lymphadenopathy. So in this condition we are going to see what is called as pseudobubo. Okay, I will tell you where we can see bubo. In two conditions we can see bubo, which is the real lymphadenopathy. One is chancroid and the other one is LGV. Please remember, in these two conditions we can see the lymphadenopathy, inguinal lymphadenopathy, which is called as bubo. Whereas in the case of this donovanosis, we are not going to see any lymphadenopathy, and this is called as pseudobubo. Okay. And in this condition, we are going to see a beefy red painless ulcer. And because it bleeds very easily on touch, that is the reason why it is appearing as beefy red. And one more point which you must remember is, just like primary syphilitic chancre, here the ulcer is hard. Here also the ulcer is hard. The genital ulcer in the case of donovanosis is hard. Okay, very very important terms, very very important. As rightly told, safety pin appearance, very good, Kirti Chaudhary. So if we take a tissue and if we crush in between the slides, if we do a crush tissue smear, we are going to see what are called as pund cells. So what are these pund cells? Basically they are the histiocytes, which are consisting of these Donovan bodies, which appear just like this closed safety pin, because of the bipolar condensation of the chromatin. We are going to appreciate these Donovan bodies as closed safety pin appearance. And coming to LGV, lymphogranuloma venereum, it is caused by Chlamydia trachomatis L1, L2, L3. And here the patients are mostly going to not see any ulcer over the genitalia. They don't see any ulcer over the genitalia. So we can say the genital ulcer is a painless transient ulcer. And as I've already told you, bubo can be seen in chancroid and also LGV. Please remember, in the case of chancroid, the ulcer is going to be seen along with the lymphadenopathy. So this we call it as concomitant ulcer positive. Whereas in the case of lymphogranuloma venereum, please remember friends, the ulcer is absent, the ulcer is transient and we can say absent. Whereas lymphadenopathy is going to be seen. Lymphadenopathy is going to be seen. That is, bubo is seen in both these conditions. Bubo is seen in both these conditions. And this is the bubo which we can see in the lymphogranuloma venereum. Please remember, related to this bubo, we have one very important sign which is called as groove sign of Grenblatt. Groove sign of Grenblatt. The reason behind this groove sign of Grenblatt is because of the enlarged lymph nodes which are present above and below the inguinal ligament. So here the inguinal ligament is there and we have this lymphadenopathy over the inguinal ligament and below the inguinal ligament, and because of this ligament not tending to give away or not tending to show any swelling, we are going to see a groove. This is called as groove sign of Grenblatt. Very, very important. Okay. So I hope all of you know who this is. This is RGV. This is RGV. I hope you all know. So with the help of RGV, you can remember lymphogranuloma venereum, lymphogranuloma venereum, lymphogranuloma venereum. So RGV likes media attention. RGV likes media attention, and the organism name is Chlamydia trachomatis. For lymphogranuloma venereum, Chlamydia trachomatis. Okay. And in the case of LGV, we are going to see the lymphatic obstruction which is going to produce the genital elephantiasis. In the case of females, it is called as estheomen, and in the case of males, it is called as ramrod penis or saxophone penis. Ramrod penis or saxophone penis. Estheomen, you can see here. Oh, I am coming in the way. I think estheomen is this image where you are able to see genital elephantiasis. Yes, Dr. V, ಹೌದು, ನಾನು ಜೆ ಎಸ್ ಎಸ್ ಅಲ್ಲಿ ಡಿಪ್ಲೊಮಾ ಮಾಡಿದ್ದೀನಿ. So few more points about this chlamydia and urethritis, which was asked in the recent INSCT exam. So urethritis is of two types: gonococcal urethritis and non-gonococcal urethritis. Gonococcal urethritis is caused by Neisseria gonorrhea, whereas non-gonococcal urethritis is caused by Chlamydia trachomatis, D2K, Ureaplasma ureolyticum, Mycoplasma genitalium, and Trichomonas vaginalis. Please remember, Trichomonas vaginalis is not only associated with vaginal discharge syndrome, but also it is associated with non-gonococcal urethritis. So one quick question for all of you: Trichomonas vaginalis, what is that? Cervix appearance is having one name in Trichomonas vaginalis, vaginal discharge. Can anyone tell what is that? What is that appearance? Thank you so much, Dr. Anand sir. Thank you so much. Yes, everyone. Gaurav, please try to answer. ಹೌದಪ್ಪ, 2 ವರ್ಷ ನಾನು ಅಲ್ಲೇ ಇದ್ದೀನಿ. ಸೊ ಕನ್ನಡ ನಮಗೆ ಅಲ್ಲಿಂದಾನೆ ಕಲ್ಸ್ಕೊಂಡಿದ್ದೀನಿ. Strawberry cervix, very good. So anyhow, I am South Indian, so I know Telugu, and because I was into Karnataka, Mysore, I learnt Kannada. I am very thankful. And because I went to Hindura Hospital, Delhi, I had to learn Hindi definitely. Yes, very good, very good. Strawberry cervix, very good. Thank you so much, Anand sir. Thank you so much. Strawberry cervix, yeah. Green frothy discharge. Okay, so this will be covered in your gynec, so I don't want to waste your time here. Green frothy discharge will be there. So in gonococcal urethritis, please remember, there is going to be very severe constitutional symptoms, whereas in non-gonococcal urethritis, constitutional symptoms are absent. And this is the picture, gram stain picture, where the gram-negative diplococci, which are intracellular as well as extracellular, can be seen in Neisseria gonorrhea. Very, very, very important point. Okay, so few important tips and tricks for you to remember. In herpes simplex virus also we can see herpes genitalis, where the ulcer as well as the lymphadenopathy are painful. So the patient will be pissed off. Patient will be pissed off because of the painful ulcer and the painful inguinal lymphadenopathy. Inguinal lymphadenopathy. And in syphilis, please remember this name instead of syphilis, remember it as syphilis, syphilis. So the ulcer is going to be painless, and also along with the lymphadenopathy is also painless. Lymphadenopathy is also painless. Okay, and though no venosus, what are the two no's? There is no pain in the ulcer and no lymphadenopathy. Please remember this. And so a brief point about approach to the genital ulcer disease. So depending upon the characteristics of genital ulcer and the characteristics of inguinal lymph nodes, we can easily differentiate these two conditions with the help of this single slide. So now you are going to answer. Yes, sir, Dr. Anand, sir. How much I am to teach you, sir? You already know a lot. So anyhow, so just we are going to see the approach of the genital ulcer disease. Okay? So please remember, if there are multiple painful ulcers. Yes, come on, friends. Multiple painful ulcers. What are the two possibilities? What are the only two possibilities? Please tell me your answer, friends, in the comment section. Genital ulcers which are multiple and painful. So what are the two possibilities? What are the two diseases which you can say? Yes, come on, friends, everybody. What are the two diseases which can be possible in this? Yes, very good. Chancroid and herpes. Chancroid and herpes. Chancroid and herpes are the two possibilities. Yes, now can you tell me if the patient has lymphadenopathy? Lymphadenopathy, in the question, if bubo is mentioned, now tell me whether we have to put chancroid here or whether we have to put herpes here. So multiple painful genital ulcers along with which bubo is present. What is your diagnosis? What should I put here? Yes, anybody? Yes, quick, come on, friends. Yes, very good, Dr. Devi Kulkarni. Chancroid. So we are left out here with herpes. So please remember, both ulcer and lymphadenopathy are painful. Both ulcer and lymphadenopathy are painful in chancroid as well as herpes. But please remember, bubo is present in chancroid and there is no bubo in herpes. Okay. So now let us move on to the other side. So a patient is coming with single painless ulcer. So lymphadenopathy is absent. So what is your diagnosis? Please put your answer in the comment section. Yes. And in the meantime, if you find this video helpful for your preparation too, please put a like for this video, and also in the chat section please put some heart for the for this video. Yes, so I told you that lymphadenopathy is absent. So please try to tell answer for this case scenario. Very good. It is donovanosis. Okay, now please try to answer. Patient is coming with single painless ulcer, bilateral lymphadenopathy, which is painless is present. So both ulcer as well as lymphadenopathy are painless. So now tell me, what is the diagnosis here? What should I put here? Thank you so much, Vivek Jain sir. Thank you so much. Sir, for all the love. Yes, come on, friends. Please try to answer this question. So here, what should I put here? Yes, very good. Dr. Sarika came up with the fastest finger first. So here it is syphilis. So patient with single painless ulcer having bilateral painless lymphadenopathy. So our diagnosis is going to be syphilis. Very, very good. Dr. Govindra Garg sir, very good evening sir. And so now we are left with only one disease, which is lymphogranuloma venereum. So patient coming with single painless ulcer and presenting with a painful bubo, so it is LGV. So I hope with this simple single slide, I hope you can answer many MCQs which are related to genital ulcer disease. Okay, I hope this is clear. Please do give a like to this video if this was helpful, friends, and also you can put some lovely emojis in the comment section. Yes, very good. LGV, it is LGV, it is LGV. Right. So now let us quickly brush through the hair topic, the rest of the topics. So we have one more topic, which is papillosquamous disorder, which is important. Okay, so in the hair, please there is some bit of lag in between me and this live chat. Yes. Okay. Thank you so much, friends. This means a lot. So there are some almost 100 students sitting in front of me, despite I am single in this room. So here the layers which are seen in the hair are, this is also a question, Huxley's layer and Henley's layer. Huxley layer and Henley's layer was asked in one of the exams. Please remember, these are the part of the hair. Okay, and we have non-cicatricial alopecia and cicatricial alopecia. So please try to remember what are the causes of non-cicatricial alopecia, that is non-scarring alopecia. Very good evening, Dr. Gaurav sir. Very good evening, Dr. Gaurav sir. So the conditions where there will not be any scarring, these are called as non-scarring type of alopecia. So we have certain varieties, patchy, diffuse, pattern and systemic variants of this non-scarring alopecia. Please remember, alopecia areata, tinea capitis of non-inflammatory variety are examples for patchy non-cicatricial alopecia, whereas in diffuse forms we have effluvium, anagen effluvium and telogen effluvium. Effluvium, wherever you find this word, please remember, shedding of the hair will be seen in those conditions. Okay, anagen and telogen effluvium. And pattern hair loss is androgenetic alopecia, which is national problem in every country. So let us quickly see some points, some very important points about alopecia areata. So this is an example for patchy hair loss. As you can see, many patches of hair loss are present over the scalp. Many patches of hair loss are present over the scalp, where there will be complete hair loss, and no signs of inflammation. That is, there will not be any erythema, there will not be any papules or pustules, there will not be any scaling present in the patients of alopecia areata. And you can see there is one gray hair which is present in this patch, which is spared, that is, it is not lost, and this is called as turning gray phenomenon or turning white overnight phenomenon, which is seen in alopecia areata. And in the case of histopathology of alopecia areata, please remember, swarm of bees appearance is seen. Swarm of bees where the lymphocytes are going to produce, the lymphocytes are going to cause damage to the proximal part of the hair. Because of this damage, what will happen? The proximal part of the hair will become thin, and the distal portion of the hair will be broad, giving a very important named sign, which is called as, very good, friends, exclamation mark hair sign. And what is the reason for this swarm of bees? Is nothing but a group of bees. So here you can see lymphocytes are present perifollicularly in the form of a group of bees. So it is called as swarm of bees appearance. So I will again appear. So in histopathology of alopecia areata, we can see lymphocytic infiltrate giving rise to swarm of bees appearance. And please remember one very important nail finding which we can see in alopecia areata is pitting pits can be seen over the nails, which are described as superficial, regular and fine. Superficial, regular and fine pits can be seen in the case of alopecia areata. So this is the geometric pitting or superficial pitting which we can see in alopecia areata. And coming to the treatment part, very important friends, it was asked in FMG exam, if the disease is localized then we can give ILS, which is intralesional steroids. Intralesional steroids can be given. Usually triamcinolone is given, and the intralesional steroids are also given in nodular scabies. Nodular scabies also we can give intralesional steroids, where nodular lesions are present usually over scrotum. Nodular lesions are present usually over scrotum. Okay, so I hope you all know this trick. ACT is the fiber net. ACT is a fiber internet. Okay, so anagen, catagen and telogen, are the phases in which the hair is going to go through. So please remember, anagen phase is a growth phase and telogen phase is a resting phase. So what is the importance of knowing this? Please remember the two conditions, anagen effluvium and telogen effluvium. So in anagen effluvium, what will happen is, because of the chemotherapy or radiotherapy, which you can see these famous celebrities also developed this anagen effluvium because of the chemotherapy which they took. The anagen phase of the hair is going to completely be lost, and please remember, almost 85% of the hair are in anagen phase in an individual. So because of the loss of all this anagen hair, the sudden appearance of the baldness is going to be seen in the individuals who are on chemotherapy, and this is called as anagen effluvium. And I hope you all know Yuvraj Singh, the great Yuvraj Singh, 6 sixers. So you will never know what you are capable of until you take that first step and go for it. Until you take that first step and go for it, no one can know what is our capability. Okay, take that first step. So coming to the next condition, telogen effluvium, please remember in the MCQ there will be mention of some major stress or post pregnancy or some kind of infection, even COVID-19. This was a previous MCQ. So patient had COVID-19, now the patient is having hair fall. What is the diagnosis? Please remember, in this condition you must put telogen effluvium as your diagnosis. Why? Because the anagen hair is going to prematurely enter into the telogen phase, because of which 3 months after the acute stress or infection there is going to be hair loss. Okay, yes, even radiotherapy is also mentioned in some books as a cause for the anagen effluvium. Okay, so now coming to adnexs and appendages, can anyone tell me what is this combination of skin and appendages called as? I will give you a clue. It is a system. So what are the appendages? Hair, nails and glands. So can you tell what is this system? Yes, can anyone tell me what is this system? Yes. It starts with I. It was a recent MCQ. It is integumentary system. Yes, very good. Okay. Yeah. So now let us quickly see some basic points about the anatomy of the hair follicle. So the goose pimples which we get are due to the erector pili muscles, and the point of attachment is going to divide the hair into upper segment and lower segment. Okay, so we are concerned more here with the sebaceous gland. So you can see the sebaceous gland is going to open along with the hair follicle. Okay. So what is the importance of this? Acne, you all might remember this as a sebaceous sebaceous disease, but please remember acne is a disorder of pilosebaceous unit. Acne is a disorder of pilosebaceous unit. Very, very important. Previous MCQ. And when these sebaceous glands are not going to open along with the hair follicle, they are called as ectopic sebaceous glands. And please remember the sites where the ectopic sebaceous glands are present. Depending upon the site, we have different names. So the most important one which you must remember are four disc spots, where yellow colored papules will be present over upper lips and also over the buccal mucosa. So these are four disc spots. So very important to remember, fox spot disease is also called as apocrine miliaria, where there will be obstruction to the outflow of the apocrine ducts. Obstruction will be there to the apocrine ducts. Okay, so in the acne vulgaris, I hope you all know that there are 4 grades. In the grade 1, we have predominantly comedones. So now let us look at some of the primary lesions. So solid raised lesion which is present over the skin, which is less than 1 centimeter in size, is called as. Thank you so much, Shrikant sir. Thank you so much. So can anyone tell me what is this solid raised lesion which is less than 1 centimeter? It is papule. And if some papules are going to coalesce with each other and if they form more than 1 centimeter solid raised lesion, we call it as a plaque. And if this lesion is going to have a deep or depth component, then we are going to call it as a nodule. So these are also some questions which can be expected in the coming exam, NEET exam or INSAT. Primary lesions, secondary lesions and special lesions, you should have an idea. So these are the papules which are able to see solid raised lesions less than 1 centimeter, and solid raised lesions which are more than 1 centimeter, this is called as a plaque. And coming to the nodule, so you are able to see here a nodule is present which is more than 1 centimeter in size and having a depth component. Yes, Dr. Devi Kulkarni, really Shrikant sir has made anatomy indeed very simple by taking almost 8 hours of continuous class. Okay, so pus-filled lesions, pinpoint sized pus-filled lesions are called as pustules, whereas large collection is called as an abscess. So these are very quick points. So in the acne vulgaris, in the grade 1, we are going to see comedones, which can be open comedones or closed comedones. Open comedones or closed comedones. In the grade 2 acne, we are going to see predominantly erythematous papular lesions, and in the grade 3, we are going to predominantly see pus-filled lesions, which are pustular lesions. In grade 4, which is the most severe form of acne vulgaris, we are going to see nodulocystic lesions. And depending upon the grade, we are having these treatment modalities. In the grade 1 acne, please remember that topical retinoids are the drug of choice in the grade 1 acne. In grade 2 acne, the treatment is going to continue the topical retinoids, add topical antibiotics. In grade 3, please remember, we have to give topical retinoids, but now we are going to add an oral antibiotic which can be minocycline, doxycycline or azithromycin. Or doxycycline. In the grade 4 acne, we are going to start the patient on oral retinoids. The oral retinoids which we are going to use in the case of grade 4 acne, can anyone tell me in the comment section what is that oral retinoid? I will give you the answer. It is isotretinoin, but please remember isotretinoin is having one more name. It is also called as 13-cis retinoic acid. This was asked in the recent exam. Very, very important. Please remember. And this is indicated in nodulocystic acne or even in resistant or recalcitrant acne. This can be used. And please remember the most common side effect which we can see in the patients who are started on isotretinoin is cheilitis. Very good, Nischay Mohit. Yes, you have answered it right. It is isotretinoin. Very good. And the dosage is also, these numbers are also important. It is 0.5 to 1 milligram per kilogram body weight, or total cumulative dose. TCD's total cumulative dose should be 120 to 150 milligram per kilogram body weight. (120 to 150), it should not exceed than this amount. And coming to the lab monitoring of the patients who are started on isotretinoin, very very important. Fasting lipid profile should be done. Fasting lipid, why? Because there can be associated abnormalities of triglycerides and cholesterol in these patients. Okay, and liver function test also should be done. And the most severe adverse effect of isotretinoin is diffuse idiopathic skeletal hyperostosis. Diffuse idiopathic skeletal hyperostosis. Yes, and isotretinoin is a teratogenic drug. Teratogenic drug. Please remember, when we start the patients on isotretinoin, we must always do a pregnancy test, urine pregnancy test, and if the patient is negative for UPT, then only we can start on the isotretinoin. And one more thing, once the patient is started on isotretinoin, at least there should be a gap of 1 month, that is 28 days from the time it was stopped till the next conception. Okay, this is very important. Why? Because this isotretinoin can be in the bloodstream for a period of 1 month. Okay, now let us move on to the papillosquamous disorders. Please remember, INSET May 2022 MCQ scales. So what are scales? Scales are nothing but visible exfoliation of the stratum corneum. Visible exfoliation of the stratum corneum is called as scaling, and there are various types of scales. So let us look at one by one. Silvery or mica-like scales can be seen in psoriasis. You can see silvery or mica-like scales are present here. Yellow greasy scales can be seen in seborrheic dermatitis. Please remember, seborrheic dermatitis, seen in infants over the scalp, is called as cradle cap dermatitis. Cradle cap dermatitis. Cradle cap dermatitis. Whereas in pityriasis versicolor, we can see brany or powdery scales. Brany or powdery scales are seen in pityriasis versicolor. Very very important. So here you can see this brany or powdery scales which are seen in pityriasis versicolor. And in pityriasis rosea, we can see collarate scales. Collarate scales can be seen in pityriasis rosea, collarate scale. Whereas fish-like scales can be seen in ichthyosis vulgaris. Ichthyosis vulgaris. So nischai teratogenic effect is the mother, if she takes the isotretinoin or thalidomide, there are certain drugs which are going to have adverse effects on the fetus. So these are called as teratogenic effects. Okay, I hope now it is clear. And also Anand sir, when sir took the class, uh, told that isotretinoin can cause one teratogenic effect in the fetus. Now can anyone tell me in the comment section what was the answer for that question which Anand sir asked in the video of pediatrics. Thank you so much, Praveen sir. Thank you so much for all the uh, thank you so much, sir, for all the support which is shown. Cleft lip, yes, very good. Ria has already answered this. Very good. Cleft lip. The image was also shown by Anand sir, if you can remember. Okay, what is teratogenic effect? I hope now it is clear. Yes, yes, yes. Right, right. And leaf like scaling can be seen in the case of pemphigus foliaceus. Pemphigus foliaceus. This was asked in INSET as match the following. All the scalings were given. So please remember, mica scales can be seen in pityriasis lichenoides chronica. Pityriasis lichenoides chronica. Very very important. Okay, so these are the list. Okay, so coming to psoriasis, it is a T cell mediated, chronic T cell mediated disorder, and there will be erythematous plaques with silvery white scaling, and various systems are affected. Please remember, various systems are affected. Joints can be involved, producing arthritis. Joints can be involved producing arthritis, and even metabolic syndrome. Metabolic syndrome is also associated with psoriasis. This was a previous MCQ, so you must have an idea regarding this. Metabolic syndrome is also associated. And few points about the journey of the stratum basal cell towards the stratum corneum. Please remember this. I hope you all know this simple trick. Come, let's get sunburned. Come, let's get sunburned. So how many of you know what is sunburn? So what is sunburn? So sunburn is a fest which happens every year in the last week of December in Goa. So it is a party basically, so which happens in Goa. So with the help of this sunburn, you can remember the layers in the order. Come, let's get sunburn. Stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basal. Come, let's get sunburned. Come, let's get sunburned. Okay. So few points I want to add here. So please remember, if there is a very low birth weight baby, then in that very low birth weight baby, stratum corneum is the layer which is going to be absent. Why? Because stratum basal, which is also called as stratum germinativum, is going to produce all the layers present above it. All the layers above it are produced by the stratum basal cell. So in this journey, the keratinocyte is going to see certain changes. What are those changes? The cells are going to get flattened and the keratin content increases and the nucleus is lost, and there is going to be dehydration of the cells and metabolism is going to become absent. Metabolism is going to become absent. So these are all the changes which happens in the keratinocyte, which is in its journey from stratum basal to the stratum corneum. And in the case of this psoriasis, you must remember that there is one important numerical which you must remember, which is called as skin turnover time or epidermal transit time or skin doubling time, which is going to be 42 to 75 days. So it is basically 56 days on an average. But if you have to remember a range, it is 42 to 75 days, which is normal skin doubling time, which is the time taken from the stratum basal cell to reach the stratum corneum and ultimately get shed off into the environment. But in the case of psoriasis, what will happen is this epidermal turnover time reduces by 1/10. That is, in 4 days time only, the cells are going to reach the stratum corneum and they are going to shed off into the environment. Okay, 4 days. Very good, short chain fatty acid. You are absolutely correct. So coming to the clinical features in psoriasis vulgaris, we have already seen silvery white mica-like scales can be seen over extensors. Extensors are going to show the silvery white scaling, and scalp can also be affected. Scalp psoriasis can be seen. Please remember, so CNS is not affected in psoriasis and mucosa is not affected, and usually there will not be any itching in psoriasis patients, and though scalp is affected, there will not be any alopecia, that is, there will not be any hair loss in the patients of psoriasis. Okay, few points about the nail. Nail plate is the visible portion of the nail. Nail bed is the base on which the nail plate is present, and nail matrix is the structure which is going to produce the nail plate. Nail matrix will produce a nail plate. So now let us see some important nail changes in psoriasis. The first one is pitting. So these pitting which you are able to see on the moon, with this I want to just remind you of this Abdul Kalam ji's quote: small aim is a crime, have great aim. So you should have a very great aim. You should not have a small aim, because if you aim for the stars, you are going to at least reach to the moon. Okay. So these are the pits which you are able to see in psoriasis. Which you can remember with the help of DIC. So there will be deep pits, there will be irregular pits, and coarse pits. Deep, irregular, and coarse pits can be seen. Very good. Very good. Yes. And in these nail changes, we can see the matrix because of the effect of the nail matrix or because of the nail bed. So because of the nail matrix, we can see pitting and leukonakia, that is white discoloration of the nail plate can be seen. Because of the involvement of the nail bed, oil drop sign, which is also called as salmon patch, which is pathognomonic for psoriasis, can be seen. And we can see onycholysis and subungual hyperkeratosis. So this is subungual hyperkeratosis. Below the nail plate, there is material which is deposited. This is called as subungual hyperkeratosis. And because of this subungual hyperkeratosis, that is material which is present below the nail plate, the nail plate will separate from the underlying nail bed, leading to onycholysis. Onycholysis is nail separation from the underlying nail bed. And here you can see the thickening of the nail in the case of nail psoriasis. So oil drop sign, it is also called as salmon patch, as I've already told you, and this is the pathognomonic. This is pathognomonic of nail psoriasis. This is pathognomonic of nail psoriasis, and we can see yellow discoloration of nail bed. Yellow discoloration of the nail bed can also be seen, as you can see here, as if a drop of oil is placed in between the nail plate and the nail bed. So coming to the histopath changes in the psoriasis, please remember we can see the retention of the nucleus, which is called as parakeratosis, and we can see absence of stratum granulosum, which is absence of stratum granulosum in the case of psoriasis is very characteristic, whereas in lichen planus you can see there will be thickening of the stratum granulosum, which we'll see in the coming slides. Please remember there is acanthosis, that is thickening of the stratum spinosum in the case of psoriasis, and the retar ridges, they are regular elongated retar ridges which are seen in psoriasis. Okay. So this is the histopath image which is showing the retention of the nucleus in the stratum corneum. Yes, Dr. Aishudev, the annotated PDF will be given. Okay. And this is the parakeratosis again, and presence of neutrophils can be seen in the stratum corneum when we call it as Munro's microabscess, and presence of neutrophilic infiltration, if it is present in the stratum spinosum, we call it as spongiform pustules of Kogoch, spongiform pustules of Kogoch. And suprapapillary thinning can be seen. So here this is the stratum corneum, this is stratum corneum, this is stratum spinosum, and this is a stratum basale, and these are the papilla, which you are able to see, these are the papilla, and above this papilla you are able to see that the thickness is reduced. This is called as suprapapillary thinning, and someone asked about the Auspitz sign. So basically what happens is the red structures which you are able to see here are blood vessels. So what happens is in the patients of psoriasis, the stratum corneum, this is the scale which is you seen clinically. So if we scrape this scaling, off this scaling, what will happen is these blood vessels are going to get exposed onto the environment, because of which there will be tiny bleeding spots, pinpoint bleeding spots which can be seen, and these, when they are seen clinically, we call it as Auspitz sign. Okay, I hope now it is clear what is Auspitz sign. It is the pinpoint bleeding spots which we can see after scraping off the scales. Okay. Yes, very good, short chain fatty acid, and Rahil Patil, you have answered it right. Very good, wonderful. So coming to inverse flexural psoriasis, so in psoriasis I told you that silvery scaling can be seen, but in the case of inverse psoriasis or flexural psoriasis, scaling will be absent, because of the excess of moisture, scaling will be absent. And here you can see inframammary folds, axilla, and also the popliteal fossa, the psoriatic changes can be seen. So systemic therapy, please remember systemic steroids are contraindicated. Very important MCQ. They are not prescribed routinely in psoriasis, but if a patient is having erythrodermic psoriasis or pustular psoriasis in pregnancy, then we do not have any other options. So in such cases only we are going to have the systemic steroids in the treatment protocol for the patients. Otherwise we are not going to use systemic steroids. Why? Because the patients can land up into erythrodermic psoriasis or pustular psoriasis. Okay. So this is a pustular psoriasis where there will be pustules seen, sheets of pus will be seen all over the body. This is called as pustular psoriasis. Okay. And the other condition is, yes, Raju Mistry Dharma. Okay. So please watch the video from the beginning. Okay, so erythrodermic psoriasis, red skin can be seen. It is also called as exfoliative dermatitis. And you can see the body surface area involvement is going to be more than 90%, and very good short chain fatty acid. Acitretin is the drug of choice in the case of pustular psoriasis. Acitretin is the drug of choice in the pustular psoriasis. Can anyone tell me what is the drug of choice in erythrodermic psoriasis? Please put your answer in the comment section, friends. What is the drug of choice in erythrodermic psoriasis? Yes? Erythrodermic psoriasis, what is the drug of choice? Yes? Yes, come on, quick question. Wonderful, wonderful. So, yes, methotrexate is the drug of choice for erythrodermic psoriasis, and for pustular psoriasis, it is acitretin. Please remember, methotrexate is also the drug of choice for chronic plaque psoriasis. Chronic plaque psoriasis, erythrodermic psoriasis, and also chronic plaque psoriasis. And what is the other name for chronic plaque psoriasis? It is psoriasis vulgaris. It is also called as psoriasis vulgaris. It is also called as psoriasis vulgaris. Okay, and the next type of psoriasis is gutted psoriasis, where we are going to have raindrop like papillosquamous lesions present over the body. Can anyone tell me what is the causative agent for gutted psoriasis? What is the causative agent for gutted psoriasis? Yes, it is a bacteria which is associated with gutted psoriasis. Can you tell what is that organism name? Yes, Kalyani Singh, you are right. Raindrop lesions are seen. What is the organism? It is group A beta hemolytic streptococcus. Very, very important. It is group A beta hemolytic streptococcus. Okay. So let us now quickly see. Yes, streptococcus. Sandeep, you are absolutely right. Group A beta hemolytic streptococcus. So here you are able to see the OSPIT sign which is being performed. With a glass slide, we are going to, scrape off the scale slowly. Then ultimately what we can see is we are going to see small, tiny pinpoint bleeding spots. We are going to see pinpoint bleeding spots in the psoriatic lesion. These are called, this is, this observation is called as OSPIT sign. This is called as OSPIT sign. And there is one more phenomenon which you must remember, which is called as Koebner's phenomenon. Koebner's phenomenon. It is also called as isomorphic response. It is also called as isomorphic response. Iso is the same, morphic is morphology. So, appearance of morphologically similar lesions along the lines of trauma over normal skin is referred to as Auspitz Koebner's phenomenon. So appearance of morphologically similar lesions along the lines of trauma over normal skin is called as Koebner's isomorphic response. And as you can see here, this patient is having psoriatic lesions, and as you can see here, this is a psoriatic lesion, and as the patient, scratches the skin due to minimal itching which the patient may have, or because of some other cause, if the patient just scratches over the skin, what will happen? Because of this trauma, along the lines of the trauma, there will be psoriatic lesions produced. This is called as Koebner's isomorphic response. Can anyone put in the comment section where can we see pseudo Koebner's phenomenon? Where can we see pseudo Koebner's phenomenon? Thank you so much, Akhilesh Yadav. Best revision video. These kind of motivational words are going to help a lot. In between the video, if you find this video helpful, please put some heart emojis also, so that it will give me motivation. So pseudo Koebner's phenomenon can be seen in which condition? And I will give you some other conditions in which Koebner's phenomenon can be seen along with psoriasis. So this can be seen in psoriasis, and along with that even in lichen planus, and also in vitiligo. we can see this. And very good, as I have got the answers, viral infections like molluscum contagiosum and viral warts which is produced by human papilloma virus, they can also show this pseudocombness phenomenon. Please remember, here we call it as pseudocombness phenomenon. Why? Because in the true Koebner's phenomenon, the underlying mechanism is autoimmunity. The underlying condition is the underlying mechanism is autoimmunity in these three conditions, whereas in these two viral infections, the underlying mechanism is auto inoculation. It is auto inoculation, so it is called as pseudocombness phenomenon. And coming to the next papilloscomus disorder, lichen planus, here we are going to see some P's which are very important. Thank you so much, friends. Thank you, Kirti, Dr. K. Thank you so much, Devi Kulkarni. Thank you, HS. So in lichen planus, we can see pruritic purple colored lesions which are present over the flexural aspect, and the lesions are papules and flocks, and they are plain topped lesions. So that is the reason why they are called as lichen planus. So these are the 6 P's which you must remember. So you can see here the purple colored plain topped papules and flocks are present over the flexural aspect. So this is a classical picture of lichen planus, very important image based question. In lichen planus we can see Wickham's tray. As you can see here, this is a beautiful image of Wickham's tray where there is a network or lacy pattern which is seen over the skin, network like pattern which is called as Wickham's tray, And in the nails, please remember, thinning of the nail plate is the most common nail finding in the case of lichen planus, whereas the most characteristic nail finding is pterygium of the nail. In pterygium, I will tell you what will happen. So other changes which can be seen are pup tent sign, where there will be tenting of the nail plate. So as you can see here, the nail plate is forming a tent-like structure, and anonychia can also be seen, which is absence of the nail plate due to the destruction of the nail plate. Okay. Yes, reticular network like lacy pattern, all of them are going to describe the Wickham's tray, which can be seen in lichen planus. These Wickham's tray can also be seen in the buccal mucosa also. That is also a very important point, friends. Please do remember this. And lichen planus nail involvement, this is the pterygium. So in pterygium, basically what will happen, this is the proximal nail fold, the proximal nail fold will encroach onto the nail plate, it will destroy the nail plate, and it will attach, the proximal nail fold will attach onto the underlying nail bed, because of which there will be wing shaped appearance seen in the nail of the lichen planus patients. So this is referred to as pterygium. I will try to erase this so that annotated PDF will have a proper image. So this is the pterygium, and a few points related to the histopath of lichen planus. So hyperkeratosis can be seen in the stratum granulosum, wedge-shaped hypergranulosis can be seen, and rete ridges, sawtooth rete ridges can be seen. Sawtooth rete ridges can be seen. So this is the hypergranulosis, wedge-shaped hypergranulosis, and here you are able to see the rete ridges. One second, let me change the color. So here you are able to see sawtoothing of the rete ridges, can be seen. And one more thing is band-shaped lymphocytic infiltrate. So this is band-like lymphocytic infiltrate can be seen. And if we zoom in this, what we can see is, we can see civate bodies or colloid bodies or cytoid bodies. They are nothing but the necrosed keratinocytes which can be seen in the lichen planus. Because of these lymphocytes, they are going to damage the keratinocytes, and they are going to produce necrosis, because of which we get to see civate borders, colloid borders, or cytoid borders. And because of the excessive destruction of the stratum basal cells, we are going to see some spaces. These are called as Max Joseph spaces. These are called as Max Joseph spaces. And please remember one very important condition, which is not a type of lichen planus, it is lichen nitidus. Please remember, nitidus means shiny, and here the description which the examiner will give you is asymptomatic flat topped shiny papules seen in children. So this is a classical description. What are the sites where these lesions can be seen? The sites are face dorsal aspect of the forearm and shaft of the penis. And in the histopath of lichen nitidus, we are going to see one very important, appearance. We are going to see important appearance. Can anyone tell what is that appearance called as in the comment section? Yes, it is called as claw clutching ball appearance. It is called as claw clutching ball appearance. So here you are able to see the claws of Michael Jordan are holding this ball. When a child is learning how to walk and falls down 50 times, they never think to themselves, maybe this ain't for me. So our attitude should also be like a small child who is falling the 50 times but again raises up the 51st time. So likewise, if we are not getting good marks in the grand test, we should not feel ashamed, we should not feel defeated. We should always try again and again. We should give the next GT with even more determination, so that our scores are going to improve a lot. Okay, that should be our attitude. So just to briefly, thank you so much, Apur Mehra sir. Thank you so much for the great, kind words, humble words. I am humbled a lot. So just to say the psoriasis and the lichen planus, what are the similarities and differences? Both are chronic inflammatory diseases, both are papilloscomus disorders. But in psoriasis, we are going to see some genetic aspect, that is HLA-CW6 association is there in psoriasis, whereas no such genetic association is there in lichen planus. And itching is not so common, or we can say absent, in the case of psoriasis, whereas in the case of lichen planus, itching is a common feature. Itching is a very, very common feature. Pruritus is one of the P's. And oral lesions and hair involvement are absent in psoriasis, whereas Wickham striae and scarring alopecia can be seen in lichen planus. Joint involvement and in metabolic syndrome metabolic syndrome are present in psoriasis, whereas in lichen planus they are absent. And in the psoriasis, we can see parakeratosis and Munro's microabscesses, and the stratum granulosum is thin or absent in the psoriasis, whereas in the case of lichen planus, we don't see parakeratosis or any microabscess. We are going to see wedge-shaped hypergranulosis, and acanthosis can be seen in both these conditions, but irregular acanthosis is seen in lichen planus. This was our previous MCQ. And in psoriasis, rete ridges are going to show elongation in the form of camel foot appearance, whereas saw-toothing of the rete ridges can be seen in lichen planus. So now coming to the next condition, which is called as pityriasis rosea. This is a self-limiting condition which is going to heal within 6 to 12 weeks. And please remember, the most common viral trigger associated with pityriasis rosea is human herpes virus number 7. And please remember, there are certain important terms related to pityriasis rosea. One of them is herald patch. Can anyone tell me what is the other name given to herald patch? Please put your answer in the comment section, friends. So herald patch, we are going to see annular lesions which will be having scales which are collarate scale, collar-like scale. Where they call as collar-like scale? Because the outer edge within the active margin of the lesion is attached. The outer edge of the scale is attached, whereas inner edge of the scale is free. As you can see, this is the outer edge of the scale which is attached, and this is the inner edge of the scale which is free. This is herald patch. Very good. Sarika has given me the answer. It is also called as mother patch. So by mother, just try to remember these two great batsmen, MS Dhoni and Virat Kohli. So our Apur sir's favorite cricket player, Dr. Apur sir's favorite cricket player, Dhoni. So can you guess why these names are put over their jerseys? because on the Mother's Day, they were wearing the shirts with their mother's name. Okay. uh, so mother patch or herald patch are one and the same, and please remember this is from the movie Jersey, which is a Telugu movie. ఆపేసి ఓడిపోయిన వాడు ఉన్నాడు కానీ ప్రయత్నిస్తూ ఓడిపోయిన వాడు లేడు. So what does this mean in English? So we can't call a person a failure if he or she never gives up on their efforts. Please do not give up on your efforts. You should try till the last minute. Definitely in this, last week, I know that certain students will feel that I have not read anything, I don't remember anything, I am a waste person on this planet. But if you continue your preparation till the last day, if you know be confident in the exam hall, then miracles will happen on the day of the results. You will not believe yourself by looking at the awesome results which you are going to get. Okay, so always have that belief. Don't stop. Okay, don't quit. Don't quit. Just do it. Okay, do it. Do it. And as rightly told by many of my students, Christmas tree pattern of lesions can be seen after the herald patch. Similar looking, small lesions will be seen along the Langer's lines, that is relaxed skin tension lines over the back. These are described as Christmas tree pattern. So now let us look at fungal infections. So non-inflammatory, non-scarring type of alopecia and inflammatory or scarring type of alopecia can be associated with tinea capitis, which is a fungal infection of the scalp, So in the case of non-inflammatory, non-scarring alopecia, we have two diseases, black dot and grey patch, and in inflammatory we have Favus and Kerion. So let us look at each of them one by one. Black dot variety, it is produced by the fungus of Endothrix variety, where the fungus is going to be present inside the hair follicle, because of which hair will break, and it will appear clinically as black dots. And coming to the next, grey patch variety, as you can see, a patch of hair loss is there here also a patch of hair loss is there, and here you can see some minimal scaling is present, where the scale is of gray color, and this gray patch variety is caused by Ectothrix variety of the fungus, which are Microsporum canis. And the next variety is Favus produced by Trichophyton Seanleni. It is endemic in Kashmir, and we are going to see special crust here, which are called as scutula. And in the case of Kerion, please remember these pointer words: boggy, indurated scalp swelling, and pluckable hair will be mentioned in the question, and there will be regional lymphadenopathy. And investigation which we can do is 10% KOH, and in the image, are you able to see there is a patch of hair loss, and you are able to see some pustules, erythema is present, there is swelling present, boggy swelling is present. So these are all the classical features of Kerion. And this is one more image where you are able to see this boggy swelling present, painful boggy swelling. Yes. So let me again appear back. So can you identify this picture where you are able to see central clearing and peripheral raised margins with scaling? This is called as, very important, annular plaque. This was also a recent exam question, annular plaque, and this is classically seen in the tinea patients, tinea corporis or tinea cruris patients. And there are various conditions which have these annular plaques, but please remember, depending upon the center, we are going to have the three differential diagnoses for annular plaque. If the annular plaque is present with central scarring, then we have this is called lupus vulgaris. If there is central clearing, then we have this tinea corporis, and if there is central crusting, we have cutaneous leishmaniasis. So you can see here there is crusting, and here there is clearing, and here there is scarring. So these are the three conditions. And now coming to the deep fungal infections, very important for the exam. I can say one question may be expected from these three conditions: sporotrichosis, chromoblastomycosis, and mycetoma. Okay, sporotrichosis is also known as rose gardener's disease, where after thorn prick the patients are going to have nodular ulcerative lesions in a linear fashion along the lymphatics. There will be proximal extension. Slowly the lesion, nodular ulcerative lesions, are going to extend in a linear fashion, or we can call sporotrichoid fashion. So as you can see here, in a linear fashion the lesions are extending. And on histopathology we can see asteroid bodies in these patients of sporotrichosis. Very important. Okay. And in the chromoblastomycosis, please remember the other name for this condition is verrucous dermatitis. It is produced by dematicious fungi, which are pigmented fungi. And I hope all of you know what does chrome mean. Chrome means color. Chromoblastomycosis. Because they are pigmented fungi, this condition is called as chromoblastomycosis, and the organism names are Fonseca pedrosa, Fonseca compactum, and Phyllophora verrucosum. So these are all the names. And this is the verrucous, cauliflower like growth is the characteristic description given for this chromoblastomycosis lesions. And you can see there are some colors present over these lesions because it is produced by pigmented fungi. And please remember, on 10% KYH mount or on biopsy we can see what are called as copper penny bodies, or sclerotic bodies, or medlar bodies, which are going to appear just like a copper penny. I hope you all have seen this movie RRR. In the initial frames, you do remember that the Britishers gave some coins to the tribal women. Those were the annas. They are the copper pennies, and because these bodies are looking like the copper pennies, they are called as copper penny bodies. Okay, in the case of chromoblastomycosis. And this is mycetoma here. So in mycetoma we can see this triad of GST. I hope you all know what is GST. One full form of GST is goods and service tax. The other full form is God, Sex and Truth, which was a movie by RGV. So G stands for granules, which can be seen exuding out through the sinuses, which are produced in the lesions which are associated with swelling. Swelling is also called as tumefaction. Okay, granule, sinuses, and tumefaction. These three are going to form the triad. Of the mycetoma. So now let us move on to the next condition, mycobacterial infection, tuberculosis verrucosa cutis, which is also called as warty tuberculosis, or this is also called as pathologist wart, or anatomist wart. So here we can see a warty growth will be seen over the buttocks or the site where there is inoculation with the tuberculous bacilli. And the other mycobacterial infection, which is the most common type of mycobacterial infection which is seen in adults. So lupus vulgaris. Please remember, it is the most common type of cutaneous tuberculosis seen in adults. Can anyone tell in the comment section what is the most common type of cutaneous tuberculosis in children? Okay, please try to answer in the comment section. Yes, so lupus vulgaris. So please remember, you can see that the lesion is going to have an asymmetry. One margin will show extension, and the other margin will show scarring. So this is the margin which is showing extension, and this is the margin which is showing scarring. So this is lupus vulgaris. And very good. Sarika has answered my previous questions. Scrophaloderma is the most common type of cutaneous tuberculosis in children, and in this you are going to see the apple jelly nodules in lupus vulgaris. And can anyone tell me what is this investigation which you are doing? A bedside investigation with a glass slide pressed on the skin. It is called as diascopy. Okay, very good. Even Dr. Kirti Chaudhary has answered scrophaloderma. So this is scrophaloderma, where it is also in some books mentioned as tubercular lymphadenitis, where the underlying lymph node or joints or bones will have the proliferation of the Mycobacterium tuberculosis. Because of the excessive proliferation, they are going to ultimately form sinuses and reach on the skin surface, producing the ulcerative lesions on the skin surface, which are called as scrofloderma. Yes, very good. As copy, you have answered it right friends, very good. So next, papillonecrotic tuberculid, it is along with lichen scrophulosaurum and erythema of Bazin. These three conditions are hypersensitivity reactions to cutaneous this Mycobacterium tuberculosis present elsewhere in the body. So in papillonecrotic tuberculid, just remember there will be central necrosis and the lesions are going to heal with scarring, and the lesions are present predominantly over the extensor aspects. The next condition is lichen scrophulosaurum. Please remember lichen scrophulosaurum, though the name of this condition has lichen, it is not a type of lichen planus. Very important point which you must remember, it is not a type of lichen planus. So it is seen in children. Lichenoid grouped papules can be seen. Lichenoid grouped papules can be seen in this fashion over the body, and it is usually seen in children, as I have already told you, and the lesions are predominantly present over the trunk. And this is a erythema induratum of Bazin, which is a lobular panuclitis, which is due to hypersensitivity reaction to the M. tuberculous bacilli. It is basically a form of inflammation of the subcutaneous fat. It is panuclitis, okay, and the nodules are present over the posterior aspect of the leg, that is over the calf, okay, and the lesions are going to heal with ulceration and scarring. And there is one very important differential for nodular lesions over the legs, erythema nodosum, where there will be nodules present over the anterior aspect of the leg, and this is an example of septal panuclitis. Very important. So now let us move on to the Hansen's disease. So quickly we are going to see the Hansen's disease. So in this, the etiological agent is Mycobacterium leprae, and the patient's lesions or the condition or the stage is going to depend upon one important criteria, which is the host immunity. Depending upon the host immunity, we are going to have various types of presentations in the Hansen disease, because of which many students feel this is a difficult topic. Okay, please remember the clinical spectrum of Ridley-Joplin's classification is the one which is used for classifying these patients into 5 varieties, which are tuberculoid variety, that is TT Hansen's disease, BT borderline tuberculoid Hansen's, the BB type, which is also called as borderline or mid borderline type of Hansen's disease. The fourth variety is borderline lepromatous leprosy, and the fifth variety is lepromatous leprosy. So as we move from top to bottom, what will happen is, in the tuberculoid pole, the immunity is very good in the patient, because of which the disease is very limited. Whereas as we move towards the lepromatous side, the immunity is reducing, so the disease is going to become disseminated. And these are the features which can be seen in tuberculoid pole, where only lesions are very less and innumerable lesions are present in lepromatous pole. And the lesions are going to become symmetrical. There are multiple lesions present in lepromatous leprosy, so it is going towards symmetry, and the margins are going to become ill-defined in lepromatous leprosy. And one nerve usually will be thickened in tuberculoid leprosy, whereas it will be multiple symmetric nerve involvement, which can be seen in lepromatous leprosy. So briefly, let us see about these types of stages. Tuberculoid leprosy, we are going to see annular plaque, where there will be central clearing. So if you remember the annular plaque with central clearing, the important DD is tinea, but please remember in tuberculoid leprosy, the lesion, this is the lesion which is annular plaque with central clearing. This is the clear part in the center. This will not have any itching, whereas in the case of tinea, there will be itching. So this is a differentiating feature between these two conditions. And please remember, in this the lesion, if it is cut and if it is seen from sideways, we can see it will have a saucer right way up appearance. Saucer right way up appearance is seen in tuberculoid leprosy. So you can simply remember T is served in saucer, which is right way up. Okay, so TT leprosy will have saucer right way up kind of annular lesions. This is how you can remember this. And the next condition is borderline tuberculoid leprosy, in which the number of lesions is going to increase, and here the satellite lesions are going to be seen. Here satellite lesions are going to be seen, which are nothing but the M. leprae are trying to jump over the surrounding normal skin and involve the adjacent surrounding skin in BT Hansen's disease. Okay, and coming to the BB Hansen disease, here we are going to see some very important named uh, uh, geographic, or we can say dimorphous types of lesions. Geographic types of lesions can be seen in this mid borderline or BB type of Hansen disease. And please remember, here we are going to see lesions which have sloping outer edges and a punched out inner border. Punched out inner border will be there, sloping edges will be there, which is referred to as saucer, which is inverted. Inverted saucer shaped lesions are the very good Swiss cheese appearance. Swiss cheese, because of this punched out appearance which is present at the center, and the outer edges are sloping like this, whereas inner border is having this punched out just like the Swiss cheese. It is called as Swiss cheese appearance. Okay, and in the lepromatous leprosy we have what is called as this infiltration of the face, which gives lion like face, which is called as leonine facies. So coming to the lion, you get what you focus on, so you should focus on what you want. If you are not sure about what you want, then you can't focus, and if you don't have a focus, then you cannot achieve it. So always you should have a laser like focus. Okay, and there is one important entity which is not under Ridley-Joplin's classification, which is called as indeterminate leprosy. Please remember, if a child is coming with facial hypopigmentation, hypopigmentation of the face, we can have two possibilities. One is pityriasis alba and the other one is indeterminate leprosy. And please remember, in pityriasis alba, which is pityriasis simply means scaling and alba is white, there will be multiple hypopigmented lesions present over the face, whereas in indeterminate leprosy usually it will be single, and scaling will be present in pityriasis alba and scaling will be absent in indeterminate leprosy. And history of atopy, that is some form of allergic history, will be there in pityriasis alba, whereas it will be absent in the case of indeterminate leprosy. And the rest of the things, skin atrophy can be present in indeterminate leprosy, and it is absent in pityriasis alba. So here in the image you are able to see these two images are pityriasis alba images, and this is indeterminate leprosy image. So you can see multiple hypopigmented patches which are associated with scaling. Yes, very good Akhilesh, we can differentiate with the help of scaling. Scaling is very important to differentiate pityriasis alba and indeterminate leprosy. And in the case of indeterminate leprosy, there will be usually single hypopigmented lesion present over the face, and it will not be associated with any scaling. And coming to the reactions, I hope you all know this rule of 5. What is that rule of 5? Please remember, there are two reactions: type 1 reaction, type 2 reaction. Type 2 reaction is also called as erythema nodosum leprosum, and the Gel and Coombs classification number 4 is a hypersensitivity reaction seen in type 1 reaction, whereas in type 2 reaction it is type 3 hypersensitivity reaction. So if you add 1 plus 4, you are going to get 5. If you are going to add 2 plus 3, you are going to get 5. So 5 is the number ultimately which you are going to get by addition of these numbers. I hope all of you know this rule of 5. If you know, please give this video a like. And these skin lesions in the type 1 lepra reaction are the pre-existing lesions. The pre-existing lepromatous lesions are going to become inflamed and erythematous, whereas in the case of type 2 lepra reaction, there will be formation of new nodules, and in the case of type 1 reaction, please remember, severe neuritis will be there. Why? Because type 1 hypersensitivity reaction, it is a delayed type of hypersensitivity reaction. It is a cell-mediated immunity, because of which there will be inflammation of the nerves leading to severe neuritis, whereas here it will be either absent or minimal inflammation of the nerves. And please remember, steroids are the drug of choice for type 1 as well as type 2 lepra reaction. So this is the image of type 1 lepra reaction, where you are able to see the existing lesion has become inflamed. Here you are able to see again, this is a patient having the type 1 lepra reaction, where the existing lesions have become inflamed, whereas in type 2 lepra reaction, there will be formation of new nodules, erythematous nodules, which are tender nodules, and these will be present usually over the entire body. Unlike erythema nodosum lesions, which are only going to be seen over the legs, in the case of type 2 lepra reaction, the tender nodules can be present all over the body. And this is the differentiation between paucibacillary and multibacillary for us to help in the treatment. So paucibacillary, the patients are going to have 1 to 5 hypopigmented or hypoanesthetic patches, whereas in the multibacillary there will be more than 6 number of these patches. And in paucibacillary, there can be no involvement of the nerve, or there can be one nerve which can be enlarged or thickened, whereas in the case of multibacillary, it will be usually more than one nerve which is thickened. And the slit skin smear is negative in the case of paucibacillary leprosy, whereas it is positive in the multibacillary leprosy. So according to National Leprosy Eradication Program, in the paucibacillary leprosy, 2 drugs are used for a period of 6 months, whereas in the multibacillary leprosy, 3 drugs are used for a period of 12 months. Okay, but we are now going to follow World Health Organization treatment regimen, where 3 drugs are used in both, but duration is going to be 12 months in multibacillary and 6 months in paucibacillary. This is the only difference. Okay, so these are the kits which we can give for the patients of Hansen. This is a multi-drug therapy which will be given for a period of 28 days. On day 1, we are going to give the patients with clofazimine 100 mg 3 tablets, which will make up to 300 mg, and rifampicin 300 mg 2 tablets, which will make up to 600 mg. So this is clofazimine and this is rifampicin. And we are going to have one more drug, which is dapsone. Dapsone is 100 mg. So these medications are going to be taken on day 1 in front of us as a supervised medication, whereas on the rest of the days the patients are going to take only clofazimine and dapsone. Okay, this is very important, and the dapsone dose is going to be 100 mg. So this is the multibacillary leprosy pediatric dosage. So I will just keep it for your reference purpose. So in the type 1 lepra reaction, we have seen steroids are the drug of choice. In the type 2 lepra reaction, also steroids are the drug of choice. But apart from steroids, we can also give the patients chloroquine. We can also give the patients chloroquine and clofazimine. And please remember, thalidomide, which is a tumor necrosis factor alpha inhibitor, is the gold standard for the type 2 lepra reaction. But still, it is not the drug of choice. Why? Because it is expensive and it is teratogenic. And now let us quickly see viral infections. So verruca vulgaris, they are asymptomatic skin-colored papules and plaques which have a rough surface, verrucous rough surface. Please remember, verruca means rough surface, and they spread by auto-inoculation. That is the reason why we have this pseudo-Koebner's phenomenon in viral warts. And these are the numbers which are asked previously. So deep plantar warts produced by human papillomavirus strain 1, superficial plantar warts produced by human papillomavirus type 2, plain warts produced by HPV subtype 3 and also 10, common warts which are produced by HPV subtype 4 and also 2, and epidermodysplasia verruciformis produced by HPV subtype 5 and 8, and laryngeal papillomatosis is produced by HPV subtype 6. Just count the number of letters which are present in larynx, LARYNX. So it is HPV subtype 6, and Butcher's warts are associated with HPV 7, BUTCHER. Butcher has 7 letters, so it is associated with number 7, and also the HPV subtype 6 is associated with anogenital warts, and laryngeal papillomatosis is usually seen in newborn babies who are born to mothers who have anogenital warts. So that is the basic reason why it is HPV subtype 6 which is associated with the laryngeal papillomatosis. Okay, so these are the plain warts which we can see, which are called as verruca plana, plain warts, and these are the plantar warts, and these are the finger like warts which are seen. These are also called as filiform warts, and these are the periungual warts. These are the periungual warts which we can see. And I hope everyone is following me with this explanation. Please do like this video if everything is understood. And molluscum contagiosum pearly white dome shaped umbilicated papules can be seen, and here you are able to see this beautiful pseudocobnus phenomenon, and you are able to see this classical dome shaped umbilicated papules, pearly white dome shaped umbilicated papules, and pseudocobnus phenomenon can be seen in this condition. Chicken pox, it will present with dewdrops and rose petal appearance. This is you might be knowing this from your microbiology knowledge. Herpes zoster, or it is also called as shingles. Very important image based question. It will be unilateral, it will follow dermatomes, and there will be grouped vesicles over erythematous base which will be very painful, which will follow a single dermatome. This is called as herpes zoster or shingles. And this yesterday in the ophthalmology class you might have heard herpes zoster ophthalmicus and associated Hutchinson's nose tip sign. And this is a Ramsay Hunt syndrome, herpes zoster orticus, which we will be discussing in ENT. And this is pigmentary disorders. Now we are coming to pigmentary disorders. Melasma, it will present with, yes, Akhilesh, we have covered 2 hours, and in few more minutes we are going to wind off this complete revision, we can say rapid revision of dermatology. I hope this is helpful for all of you. So in melasma, malar area, mandibular area are going to show brown, black or bluish hyperpigmented macules and patches. Whereas this is very important image, chikungunya fever. So the examiner will give a patient is having fever, for which joint pains were also present, for which NSAIDs were taken by the patient, followed by which this hyperpigmented macules are developing over the nose. Okay, so what is the diagnosis? Please remember, it is a post chikungunya fever, melasma like rash or hyperpigmentation which is present over the nose, which is called as chikungunya. Very important question. It was asked so many times. And now let us look at some dermal melanocytosis, and the first one is Mongolian spot, which can be seen in infants, and you are able to see this bluish green discoloration present over the lumbosacral area. This is called as Mongolian spot. And basically these condition, Mongolian spot, nevus of Ota and nevus of Ito, are seen because melanocytes are actually present in the stratum basal. So stratum basal is the actual Aadhaar address for the melanocytes, but in these conditions what happens is the melanocytes, they cannot reach the stratum basal. Instead they are arrested in the dermis, because of which there will be skin which shows blue to slate gray color. And in the case of nevus of Ota, there will be facial involvement. Even sclera can also be involved in nevus of Ota. So you can remember simply with the trick, nevus of Ota, O for Ota and O for ophthalmology involvement, that is scleral involvement is there. So with the help of this you can remember easily that nevus of Ota is associated with face, and this is nevus of Ito. where over the shoulders the lesion can be seen. That is the bluish discoloration can be seen over the shoulder. The very important differential for nevus of Ito is Becker's nevus. Becker's nevus. So please remember, Becker's nevus is androgen sensitive condition where there will be brown pigmentation, and along with that, along with hyperpigmentation, there will be hypertrichosis also. In the case of Becker's nevus. So this is amiodarone induced facial pigmentation. Very, very important recent question. So amiodarone induced cerebelloderma like facial pigmentation. This is pibaldism where we can see this white forelock, and along with the islands of normal skin can be seen within the white patches over the trunk. So islands of normal skin you are able to see in the white patches. This is segmental vitiligo. Vitiligo basically is because of the autoantibodies against the melanocytes. And in the segmental vitiligo, we can see unilateral segmental depigmented macules as well as patches. Depigmented macules and patches will be seen in a segmental fashion in a unilateral dermatomal involvement. And here the patients are going to get a better outcome with surgical intervention instead of any medical treatment. So now let us quickly see some nutritional dermatology related topics. Frenoderma. So here we are going to see hyperkeratotic papules or extensors. Can anyone tell in the comment section what is the vitamin deficiency which is associated with frenoderma? What is the vitamin deficiency which is associated with frenoderma? Please put your answer in the comment section, friends. Yes, very good. Waardenburg syndrome is also associated with pibaldism, in which case we can see some other conditions, some other associated conditions like sensorineural hearing loss can be seen, and there can be increased distance between the medial canthi can be seen. So these are the other associated conditions in Waardenburg syndrome. Yes, it is also called as toad-like skin, and vitamin A deficiency is the important association with this frenoderma. Very good. Even essential fatty acid deficiency can also cause this. Even vitamin C and vitamin B deficiency is also associated with frenoderma. This is a recent, update which we got. That is, frenoderma can be associated with vitamin A, C, and B, and essential fatty acid deficiency. But please remember, vitamin K deficiency is not associated with frenoderma. And this is vitamin B2, that is riboflavin deficiency, which is going to manifest with angular stomatitis, which you are able to see here, angular stomatitis, and there will be neovascularization of the cornea, as you can see here. And this is pellagra, very, very hard topic for the examiner. It is very, very important. Can anyone tell me what is this necklace? What is the name of the necklace? There will be basically 3 Ds in this disease: dermatitis, dementia, diarrhea. So diarrhea, dementia, dermatitis. This dermatitis is precisely photodermatitis, and this is called as Casals necklace. Very good. It is niacin deficiency, and this is called as Casals necklace. In pellagra, please remember 3 Ds were present, and if not treated properly, death can be seen in the patients. Whereas in the case of zinc deficiency, we are going to see a condition called as acrodermatitis enteropathica. There are certain similarities and certain differences between these two conditions. So just for the quick review, acrodermatitis enteropathica, the absorption of zinc is problematic, and we can see in these patients presence of dermatitis and diarrhea just like pellagra, but here the third component is alopecia. Okay, that is the only difference. And the patients are going to need lifelong zinc supplementation. Lifelong zinc supplementation is what is necessary in the patients of acrodermatitis enteropathica. So let me again come back to the picture. So this is curvy vitamin C deficiency, which will manifest with perifollicular hemorrhages, and there will be bleeding gums. And this is granuloma annulare, which is a necrobatic disorder, which was asked in the recent exam. So annular lesions will be seen. In tinea corporis also annular lesions can be seen. Central clearing can be seen, and in tinea corporis also central clearing can be seen. So how to differentiate these two conditions is simple. Complaints of itching will be there in the tinea corporis, and the patients of granuloma annulare are completely asymptomatic, and scaling is present in tinea patients, scaling is absent in the patients of granuloma annulare. So that is how you can differentiate these two conditions. Now let us quickly see the malignancies. So A, B, C, D, E, asymmetry, border irregularities, color disparities, and diameter more than 6 millimeters, and evolution of the lesions in malignant melanoma are very, very important findings which we can see in malignant melanoma. So this is lesion of malignant melanoma. So few important points about malignant melanoma. The types: superficial spreading type is the most common type of malignant melanoma, where the pre-existing mole or nevus is going to turn out to become a melanoma lesion, and nodular melanoma is the most aggressive type of melanoma. Lentigo-malignant melanoma is the most common type in elderly, and acral lentiginous is the most common type of melanoma seen in dark-skinned individuals. So these are some of the images. If the history says that a patient had previous mole which is now having this ABCD changes, that is pre-existing mole is now having this ABCD changes, then we can mark the answer as superficial spreading melanoma, and this is acral lentiginous melanoma, and this is a nodular form of melanoma. And this is a subungual melanoma. In which we have this Hutchinson sign, which simply means that if there is a linear melanonychia, that is black nail, and you have to observe the proximal nail fold. If the proximal nail fold is having this blackish pigmentation, then we can say that it is a subungual melanoma. And basal cell carcinoma, it is the most common primary malignancy of the skin, and risk factors are PUVA therapy. And please remember, basal cell carcinoma is a locally invasive tumor. And as you can see here, pearly white papillonodule can be seen, with the surface showing enlarged blood vessels, it is telangiectasious, and we can see that there will be formation of ulcers. Ulcers will be formed, and these ulcers are called as rodent ulcer. Very good. They are called as rodent ulcers. And the site of involvement, you can remember, if you draw a line from angle of mouth to the tragus, above this line is the site where most commonly basal cell carcinoma is going to be seen. There will not be any metastasis, there will not be any lymphatic spread. It is only locally invasive. Okay, the treatment can be topical imiquimod if it is superficial BCC, and MMS, most micrographic surgery can be done. Some paraneoplastic conditions, acanthosis nigricans, the patients are going to present with hyperpigmented velvety plaques in the neck and axilla, and most commonly the cause is obesity in these individuals, and rarely even malignancy like adenocarcinoma. And obesity and diabetes are important for you to remember, and there will be increased insulin-like growth factor in these patients. Coming to the seborrheic keratosis, if the elderly patient is having gastric adenocarcinoma, then what will happen is there will be rapid onset of seborrheic keratosis. So these are the seborrheic keratosis. So this is called as sign of lesser Trellat. That is sudden appearance of explosive numbers of seborrheic keratosis lesions in elderly individuals should raise a suspicion of gastrointestinal adenocarcinoma. And glucagonoma, we are going to see necrolytic migratory erythema. Glucagonoma, we are going to see necrolytic migratory erythema. I will show you the image. It will look like a tinea lesion, but the only difference is at the periphery of the lesion there is going to be vesicles which are present. Okay, so these are the tinea like lesions, but at the periphery there will be vesicular lesions. This is necrolytic migratory erythema which can be seen in patients of glaucoma, and this is a patient of CA lung who can have a skin lesion in the form of erythema gyratum repens. Erythema gyratum repens, where the lesions look like a wood grain, that is a tree. If we cut a tree, then we are going to see this kind of gyratum like lesions. Gyratum like appearance can be seen in the wood if we cut it. So similar appearance is there over the skin, so this is called as erythema gyratum repens. So few more points about the connective tissue disorders and drug, and we are going to wind up this discussion. So discoid lupus erythematosus, coin shaped lesions are seen here. That is the reason why it is called discoid blocks. There will be central atrophy and peripheral hyperpigmentation can be seen. As you can see here, this lady has peripheral hyperpigmentation. And we can see carpet tax sign or cat tongue sign or tin tax sign positive in the patients of discoid lupus erythematosus. Discoid lupus erythematosus. And in systemic lupus erythematosus, please remember malar rash will be present, involving the bridge of the nose and also over the malar areas bilaterally, and nasolabial folds are usually spared. And the important differential diagnosis is rosacea, and you can easily differentiate rosacea and SLE because in rosacea there will be some history of the triggers: spicy food intake, sunlight, stress, alcohol intake. All this will be given, whereas the history will be not given in systemic lupus erythematosus. Whereas in SLE, please remember there will not be any papules or pustular lesions, whereas in rosacea we can see papules and pustular lesions present. The erythema which is seen in SLE is a fixed type of erythema, and also systemic features like arthritis, arthralgia, fever will be present in systemic lupus erythematosus, whereas they are all absent in the case of rosacea. And coming to the next connective tissue disorder, dermatomyositis, please remember Gottron's papules, Gottron's sign are very important. They are violaceous macular erythema which can be seen in these patients. Along with skin lesions, they are going to have proximal muscle weakness, So is there any other problem? Yes, very good Aditya Singh. Even in pemphigus foliaceus and also in the case of pemphigus foliaceus along with the seborrheic dermatitis, we can see carpet taxon. So heliotrope rash, very warm welcome for the new students who are joining. Okay, heliotrope rash, violaceous hue can be seen in the periorbital areas. So violaceous macular edema or erythematosus, this is heliotrope rash. So dermatomyositis, we can have one more condition where there will not be any inflammation, and it is called as mechanics hands, where there will be the skin is going to become very thickened. Skin is very thickened, and it is associated with anti-Jo1 antibodies. And can anyone tell me what is the picture which I am trying to show you with Angelina Jolie? This is called as one sign which is called as holster sign. Holster is a pocket where the extra guns are placed, and these holsters are present usually over the lateral aspect of the thigh. Okay, so lateral aspect of the thigh. This is violaceous macular erythema is seen in dermatomyositis patient. And connective tissue diseases. So localized scleroderma is which is a morphia. If it is seen in a linear fashion over the forehead with the involvement of the scalp, we call it as N-Coupe D saber. Here the alopecia is going to be of scarring type of alopecia can be seen. And this is a fixed drug eruption. Where well demarcated circular dusky red blocks can be seen So this is a classical description, and the drugs which are associated are NSAIDs, cotrimoxazole tetracycline intake is going to cause this eruption, and the classical feature of this condition is the recurrence of the same lesions at the same site when the patient takes the same drug. Okay, that is the classical feature of this condition, and the lesions are going to heal with a very bad hyperpigmentation. And the next condition is erythema multiforme, where special lesion, target lesion or iris lesion or bull's eye lesion can be seen. So this is going to have three important zones. The first zone is the central zone, which can have vesicle or bulla, and it is usually erythematous, that is red in nature, and intermediate zone, it is pale because of the edema, and a peripheral zone of redness or erythema can be seen. So these are three zones, and if you want discipline, you have to get focused. You will never hit the bull's eye if you are aiming at multiple targets. Okay, please remember this important point. Be focused. Be focused. And this is a dreaded complication: SJS and TE and SJS and TN, Steven-Johnson syndrome and toxic epidermal necrolysis. So in which case mucosal involvement will be seen with painful erosions which are covered by hemorrhagic crust, and depending upon the body surface area, if less than 10% of body surface area is involved, it is SJS. If more than 30% of body surface area is involved, it is toxic epidermal necrolysis, and if it is in between 10 to 30%, we call it as an overlap of SJS and TN. So that with this we come to end of this session. So I just want all my students to sing along with me this song which inculcates confidence among us. हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन, ओहो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन. Okay, so what does this mean in English is we will be successful, we will be successful, we will be successful one day. We have faith in our mind, and I have full faith. Okay, we will be successful one day is what this means. And please remember, జీవితం ఎవరిని వదిలిపెట్టదు, అందరి సరదా తీర్చేస్తుంది. Definitely we are having so many issues going on right now with so much of disturbance going on outside. You all know what is the issue happening right now, so we don't know what will be the result, but I want all my students to be focused. I hope this session was helpful. Please do give the video a like, and also put some beautiful heart emojis under this video if this was helpful. Govindrai Garg sir, yes sir, we all will be successful. The students will be successful in this exam itself, and I wish that they don't need any app, not only just our Cerebellum Academy app, but if the students are watching for the next year exam, please you can consider taking up the Cerebellum Academy app. Okay, and excellent. Thank you so much, Govindrai Garg sir, Goga sir, our own Goga sir. And yes, can we do you know what are these are lyrics from Lakshya movie. So I hope I was okay with singing. Can I sing this song? Do you think I can sing? Or let us move on to the next. Virtual likes. Thank you so much, Aditya Singh. Thank you so much for all the love. So this is what you must remember. We can't call a person as failure if he or she never gives up on their efforts. ఆపేసి ఓడిపోయిన వాడు ఉన్నాడు, కానీ ప్రయత్నిస్తూ ఓడిపోయిన వాడు లేడు, ఇప్పుడు లేడు. సో థ్యాంక్ యూ సో మచ్ గర్గ్ సార్. సో let us see quickly is लक्ष्य है तेरा. I will sing. Okay. हाँ यही रास्ता है तेरा, तूने अब जाना है. हाँ यही सपना है तेरा, तूने पहचाना है, तुझे अब ये दिखाना है। रोके तुझको आंधिया या जमीन और आसमां, पाएगा जो लक्ष्य है तेरा, लक्ष्य तो हर हाल में पाना है। मुश्किल कोई आ जाए तो, पर्वत कोई टकराए तो, ताकत कोई दिखलाए तो, तूफान कोई मंडलाए तो, मुश्किल कोई आ जाए तो, पर्वत कोई टकराए तो, बरसे चाहे अंबर से आग, लिपटे चाहे पैरों से लाख, बरसे चाहे अंबर से आग, लिपटे चाहे पैरों से लाख, पाएगा जो लक्ष्य है तेरा, लक्ष्य को हर हाल में पाना है। So what does this mean is, at any cost we are going to achieve what we are targeting or what we are focused upon. This is the meaning of this lyrics. These are from Javed Akhtar's lyrics, the great persons. Okay, so let us complete this song itself. हिम्मत से जो कोई चले, धरती हिले कदमों तले, क्या दूरियां क्या फासले, मंजिल लगे आके गले, हिम्मत से जो कोई चले, धरती हिले कदमों तले, तू चल यूं ही अब सुबह शाम, रुकना झुकना नहीं तेरा काम, तू चल यूं ही अब सुबह शाम, रुकना झुकना नहीं तेरा काम, पाएगा जो लक्ष्य है तेरा, लक्ष्य तो हर हाल में पाना है। हाँ हाँ यही रास्ता है तेरा, तूने अब जाना है, हाँ यही सपना है तेरा, तूने पहचाना है, तुझे अब ये दिखाना है। Okay, I hope this was helpful. Indian Idol doesn't deserve talent. The show is horrendous. Thank you so much, friends. आप मुंबई आ सकते हो. Delusion postponed, no edit. Or you share some spotters of clinics. Thank you so much. गलत फील आ गए गर्ग सर, थैंक यू सो मच। हिंदी इज अमेजिंग या, हिंदी 2 साल तो सीख लिया है तो पर इस सेशन में मैंने हिंदी इसलिए इस्तेमाल नहीं किया क्योंकि हैव सीन बहुत सारे स्टूडेंट्स कंप्लेंट कर रहे थे कि हिंदी में बात कर रहे फैकल्टी, सो इसीलिए मैंने हिंदी एक्चुअली इस्तेमाल नहीं किया, पर मुझे अच्छी हिंदी आती है। आई एम एक्चुअली गोइंग टू रिकॉर्ड हिंदी इंग्लिश वर्जन वीडियोस ऑल्सो, and I hope we can end this session with this my favorite dialogue from Businessman. గుర్తుపెట్టుకో, నీకంటే తోపేవాడు లేడు ఇక్కడ, నీకు ఏదనిపిస్తే అది చెయ్యి, ఎవడి మాట వినొద్దు, మనిషి మాట అసలు వినొద్దు, నీ టార్గెట్ 10 miles అయితే ఎయిమ్ ఫర్ ది 11th mile, కోడితే దిమ్మ తిరిగిపోవాలి, చల్. సో దిస్ ఇస్ మై ఫేమస్ డైలాగ్. So what does this mean is, don't listen to anybody's words, don't give a shit, don't give a damn to anyone's words. If you are doing something good, if you feel that what you are doing is correct, you must just keep doing that. Don't bother what others are saying. Others may demotivate you, others may tell that you can't do it, others may tell it's not possible for you, but just prove them wrong with your results. Okay, prove them wrong with your results, not with your words. Okay, so that's it in this video, friends. Thank you so much. Happy learning dermatology. బుల్లెట్ దిగిందా లేదా, ఎప్పుడు వచ్చా అన్నది కాదన్నయ్య, బుల్లెట్ దిగిందా లేదా అది ముఖ్యం. ఓకే, ఆఫ్టర్ ద ఎగ్జామ్, ఓకే, ఇఫ్ ఎవ్రీథింగ్ గోస్ వెల్, ఆఫ్టర్ ద ఎగ్జామ్ విల్ హ్యావ్ అ లైవ్ సెషన్ అండ్ బుల్లెట్ దింపేద్దాం. ఓకే, థ్యాంక్ యూ సో మచ్. హ్యాపీ లెర్నింగ్ డర్మటాలజీ అండ్ హ్యాపీ లెర్నింగ్ ఆల్ ద సబ్జెక్ట్స్, హ్యాపీ రివైజింగ్ ఆల్ ద సబ్జెక్ట్స్. Sarvam Sri Krishnarpanam Sarve Jana Sukhino Bhavan. Thank you so much for all your patient listening for 2.5 hours. Okay, almost a movie. So we have seen a movie called dermatology. Okay, dermatology by DRMSD, Dr. Maddineni Srinivas. Okay, I hope it was helpful. If it was helpful, please do hit that like button and do subscribe to Cerebellum Academy YouTube channel, and do follow Cerebellum Academy on Instagram, Telegram, so that you will get the notifications. But I would suggest you not to have these apps on your primary phone. Have a separate phone with all these apps, but keep a very basic model phone with you while you are studying, so that you are not going to get distracted because of all these notifications from the apps. Okay,